Our aim was to clearly and succinctly describe the boarding crisis in emergency departments and its consequences, and to propose actionable solutions. My name is Joseph Berliand. I'm an assistant professor of emergency medicine at Brown University and the associate director of quality and patient safety for the Department of Emergency Medicine. Our article title is Boarding, Healthcare's Dangerous Bottleneck, and it will be in the January 2026 edition of Mayo Clinic Proceedings. My co-author is Ali Adashi. He is a professor of medical science and former dean of medicine and biological sciences at Brown University. Emergency department crowding is a major crisis that is impacting the quality of care in emergency departments and is largely driven today by boarding patients. Boarding is the practice of holding patients in the emergency department after the decision to admit has been made. This usually happens because there are no available staffed inpatient beds. The reason this is so detrimental to care is that boarding patients rely on scarce emergency department resources to care for them. They rely on emergency department nurses who are simultaneously trying to care for newly arriving patients. They use our emergency department CT scanners and imaging resources and require the attention of our technicians and physicians. They additionally often occupy private emergency department rooms while relegating new emergency department arrivals to be seen in curtained hallway and other makeshift spaces with less privacy. Overall, what all of that means is that having boarding patients in the emergency department in the ED reduces the functional capacity to care for new arrivals. This creates a bottleneck, and it leads to a decrease in the ability to see new patients and carry out orders for sick patients who are arriving to the ED. We know that when boarding is high, it has been well demonstrated in the literature that this leads to increased patient morbidity. It leads to increased patient mortality. It causes more hospital-acquired delirium for patients who are in the emergency department and not just those that are boarding. It raises costs for hospital systems. It increases the percentage of patients who arrive to the emergency department and choose to leave without being seen. It results in increased violence against healthcare workers, and it results in longer hospital length of stays. All of these negative consequences have been very well documented in the literature. And because of that, the Joint Commission actually recommends that boarding is kept to less than 4 hours, if at all possible. Despite all of this, the boarding crisis is not that well known to the public, and it is not even well known to healthcare leaders who practice outside of the emergency department. And that's a large reason why we wrote this piece. Moreover, there are no clear mandatory quality metrics that are mandated and pay for performance in the United States that measure boarding. In the current state, hospitals try to mitigate the impact of boarding through innovations in patient flow. What that means is they institute models of care that try to decrease the impact of boarding. For example, by placing a physician in triage in an emergency department, or creating a fast track zone, or an observation unit, or even a surge protocol where patients who are boarding in the emergency department at a critical level are brought upstairs to the inpatient units to board in hallway beds. Most of these kind of solutions, they chip away at the problem by mitigating the effect on the quality of care and by reducing the impact on patient safety, but they don't actually address the underlying causes of boarding. At the moment, hospitals are not incentivized to try to address the underlying causes of boarding, which are multifaceted. Currently, there are big bottlenecks for outflow of patients from the hospital, and it's hard to get patients out. There aren't enough skilled nursing facility beds. There aren't enough rehab beds. There is a decrease in access to outpatient care across this country, which means that if a patient requires rapid outpatient care that has traditionally been able to be managed without an emergency department visit, nowadays they might have to come to the emergency department to actually get treated for the same things. All of these lead to higher influxes of patients, and at the same time, hospitals are not prioritized to care for the boarding patients. Currently, they are incentivized to try to care for those patients who are being treated post-procedurally from things that provide better reimbursements to the hospital system in order for the hospital system to stay afloat. And so there is a competing interest between caring for the emergency department boarding patients and caring for other patients who have very necessary procedures, but are vying for the same resources as those who are in the emergency department. Our general suggestion is that while it is extremely important that hospitals continue to innovate to try to decrease the impact of boarding, and this is very important for patient safety, it is also important to try to create an incentive structure nationally so that hospitals invest in reducing boarding. One way to do this is to have a national quality organization like the Centers for Medicare and Medicaid Services, CMS, actually mandate, collect, and publicly report a metric on boarding. A way to do this would be to do something very clear, such as reporting what percentage of emergency department patients who board for greater than 4 hours, setting a target, and having that be a pay-for-performance metric that is publicly reported. Something like this would incentivize hospital systems to invest in infrastructure improvement, to invest in increasing outpatient capacity, and perhaps even invest in technology, such as the use of artificial intelligence to predict boarding surges, or to better assign beds to patients to minimize the harm from boarding, since boarding harms different patient populations in different ways. Our whole commentary directly relates to clinical practice. Our aim through this is to raise attention of the crisis and help improve patient care for the emergency department. Ultimately, if hospital systems are incentivized to invest in solutions to the boarding crisis, this will lead to patients having a better quality of care and to have safer care in the emergency department. For more details about the boarding crisis, its impacts on patients, and potential solutions, please read our commentary in the Mayo Clinic Proceedings.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings, or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.